Good morning, everyone.
Good morning, ma'am.
Good morning, ma'am.
Can you hear me?
Yes, ma'am.
Yes, ma'am.
Okay. Do you have any questions till yesterday's class? Have you understood till yesterday's class? No response.
Yes, ma'am.
Okay, today we'll start with another class. So this is 4th class of blood transfusion. So I'll be sharing you the slides. Can you see?
Yes, ma'am.
Okay.
Yes.
So, okay. So today we'll start with the another class of the transfusion medicine. So I hope by this time you must have understood the previous classes. If you haven't understood, then you can ask me at the end of the class. So now today we'll be discussing about what are the anticoagulants used in the blood, this banking, or in case of the blood bags. And then we will see the blood grouping and then the cross matching, how blood grouping is done and how cross matching, that blood grouping part I have already told you, and how the cross matching is done. And then Coombs test we will see, and storage of blood, and then the basic screening test. Basic screening test in the donor we will do, and also we will do the basic screening test in the recipient also. So I'll be discussing about all these things. So now first we'll come to the anticoagulant. So here in whenever the blood is taken out from a donor and then it is kept for the storage, that time the blood will clot, isn't it? So you must have seen whenever the blood comes out of the body, it will clot, and so it will prevent the bleeding, isn't it? So in the cut wound, injury and all. So now here we are taking out the blood and then we want to store it for a longer duration of time. So here we will use the anticoagulant. So there are different anticoagulants are used. So here one is the ACD. Here the A stands for the acid, and then C for the citrate, and then the D is for dextrose. And in case of the CPD, C stands for citrate, P stands for the phosphate, and D stands for dextrose. And in case of the CPDA, same thing, citrate, phosphate, dextrose, but the A stands for the adenine. Understood here? So here heparin is also one of the anticoagulant, but heparin we don't use it in case of the blood bags. Understood here? So we use the three. Either we use ACD, CPD, or CPDA. So heparin is also one of the anticoagulant, but we can use this heparin whenever we transfer some of the blood samples. That time we use in case of the blood gas analysis. So here just name only, but you have to remember that, okay, ACD, CPD, and then the CPDA. CPDA is latest, and then it is stored. The CPDA works for the storage of the blood for longer duration of time. Now we will see, so till how much time this blood will be stored. So here you see here ACD is there, CPD is there, and then the CPDA is there, isn't it? So now in case of the ACD, citrate is, so all these milligram, how much component, how much quantity, this is not required, but still if you know, then that will be better. but we will not ask in Viva and all, but you have to know the ACD, CPD and CPDA and what it stands for ACD and CPD, that you have to tell. So citric acid, here in case of the ACD, it is the 8 gram per liter, and the sodium citrate is 22 gram per liter, and then the dextrose is, D stands for dextrose, isn't it? So here D stands for dextrose, and then it is 24 gram per liter. So this ACD, it doesn't have this sodium biphosphate, or this phosphate is not there, and adenine is not there. And in case of this, whenever this ACD is used as anticoagulant, we can store the blood up to 3 weeks. Understood here? In case of the CPD also, see here, the citric acid is 3.3 gram per liter, and then the sodium citrate is 26 gram per liter, and dextrose is 26 gram per liter. So now here, more than the ACD, the glucose is more, isn't it? So 26 gram per liter, and here the sodium biphosphate is there, or phosphate is there, that is the 22 gram per liter. So here it also stores for 3 weeks, but it is better than that of the ACD. And now we'll come to the CPDA one. So now here, in case of the CPDA, the citric acid or the citrate is 3.3 gram per liter, and then the sodium citrate is 26 gram per liter, dextrose is 26 gram per liter. And here the adenine is added. So here this adenine 0.28 gram per liter, it is kept, and its component is this much. So here this CPDA will be able to store the blood for up to 5 weeks. See, now previously it was up to 3 weeks, now it has become up to 5 weeks. So the best one is the, so if you tell the name of the anticoagulants, ACD, CPD or the CPDA, so you have to tell that which is the best. CPDA is the best. This slide, did you understand?
Yes, ma'am.
Okay, so all these component, how much it is not necessary, but the name only. If you don't know the citrate, first A stands, at least you have to tell the ACD, CPD and the CPDA. So in the blood bank, we will store the blood in the temperature like 2 to 6 degrees Celsius. Understood here? Usually the storage temperature we will maintain in the blood bank at 4 degrees Celsius, but usually it can be stored in a range of the 2 to 4 degrees Celsius, but here we maintain the 4. Sometimes it becomes 4.26 something, but still you have to maintain at the 4, so that the blood can be stored for up to 5 weeks or 3 weeks. So now how the citrate, or what does it do? This anticoagulant composition citrate is there, isn't it? So other citric acid was there. It is also known as the citrate. So it acts as anticoagulant by chelating the calcium. So citrate prevents clotting of the blood. So whenever this calcium is chelated or calcium is removed from the blood, then that time it will not cause the coagulation of the blood. So it acts as anticoagulant by chelating the calcium, means the citrate will prevent the clotting of the blood. Understood this one? So citrate, you remember C for calcium, so it will remove or it will chelate the calcium. Chelating means, do you know the word chelating? Removing. Suppose it's a medical term, chelating. So whenever there is increase in case of the thalassemia, whenever there is the more and more blood transfusion is there, that time the iron deposition will be there. So we will give the iron chelating substances, so that from the body the iron deposition will be removed. So here the citrate chelating means citrate will remove the calcium so that the blood will not clot. Clear? Now we will see what does this dextrose do. So here dextrose is a glucose, isn't it? So here it increases the viability of red cells. Whenever the citrate is there, now the viability of the red cell will be decreased, but the dextrose will increase the viability of the red cells whose viability is decreased by the citrate. Understood here? So viability of the red cell decreases rapidly in citrate, though it prevents clotting. So now citrate, we will use it as a chelating substance, but now here, now you know the blood store, how many days the blood can be viable in our body? Anybody who can say? Lifespan of RBC, how many days are there?
120.
120. 120.
120 days, isn't it? So, but whenever it is removed from the person's circulation, then it has got not much life, but we have to keep under the anticoagulant substances, and we have to give the dextrose for its viability, isn't it? So here the viability of the red cell decreases rapidly in the citrate or in the citrate solution, but this dextrose helps in preventing the this decrease of the viability. So addition of the dextrose increases the post-transfusion survival of the red cells. Post-transfusion means, so whenever the dextrose having solution, this red blood cells or the blood is transfused, so even going in the recipient's blood also, it increases the survival of the red cells. And dextrose is necessary for the cell metabolism of the stored red cells. So now every cell, it has got its metabolism, isn't it? So here dextrose will increase the cell metabolism of the stored red cells, so that the RBCs can be stored for a longer duration of time, or it can survive for a longer duration of time, that is up to 5 weeks. Understood here? Now what this adenine does? So it increases the post-transfusion survival of the red cells. So this adenine will also increase the post-transfusion survival of the red cells. And adenine containing the blood is superior with respect to ATP concentration and viability. So it means that adenine, whenever CPDA was there, isn't it? So as an anticoagulant, so whenever this adenine was added, now the blood storage duration was increased to the 5 weeks, isn't it? So here this adenine containing the blood is superior with respect to the ATP concentration and viability. So in the blood, there will be the ATP concentration will be there, and its viability will be increased. And ATP, you know that it is needed for the metabolism. This much you understood? Now, anticoagulants, anything you want to ask? So basic only you have to know that, okay, citrate will remove the calcium, or it will chelate the calcium, and then it will prevent the clotting, and then dextrose, it will give the this energy for the RBCs, isn't it? So dextrose is a glucose, isn't it? So it will increase the viability of the red cells even after the transfusion. And adenine also, it will increase the ATP concentration, so that the viability of the red blood cells will be increased. Understood here? So now we'll come to the cross matching. So cross matching means cross matching of the donor and then the recipient sample is done. So whenever we want to give the blood to the patient, that time we have to do the cross matching. Cross matching means, so donor's blood is also taken, and then the recipient's blood is also taken, and then we will mix it up, and then we will see that whether it is matching or not. So matching or not means if the RBCs are not agglutinated, then it means that the blood is matching. If the RBCs are clumping and then agglutination, it will show the blood sample is not matching. So that's why in those cases we will not give the blood. So cross matching means cross matching of the donor and then the recipient sample. Understood here? So it is most important test before the blood transfusion is done. So in every cases of blood transfusion, we will do the cross matching of the blood, and then we will only transfuse the blood. Otherwise, without this cross matching, we will not do. Are you listening to me?
Yes, ma'am.
Okay. So cross matching means here we will mix cross match, isn't it? So we'll mix the RBCs of the donor as well as we'll mix the RBCs of the recipient, and then whether it will match with each other or not. So match with each other means we will see whether there will be the agglutination or not. So if agglutination is there, so it's not matching, we will not give the blood. But if there will be no agglutination, RBCs are separately placed, and we can see under the microscope also the singly spaced RBCs. So we'll give that blood to the recipient. So it is most important test before the blood transfusion is done. So this cross-matching, it will prevent the transfusion reactions by detecting antibodies in the recipient serum. So now the blood is going to the recipient, isn't it? So that time, if any antibodies are there in the recipient serum, so it will detect that. Usually whenever a blood is collected or a donor gives the blood, we will do the screening of the donor, and then we will see so many things like whether the person is having any disease or not, whether person is having antibiotic or not, and any this malignancy is there or not, diabetes there or not. So many things we will do screen, and usually a donor will be a healthy donor, isn't it? So but here the recipient will have some diseases. That's why. So it cross-matching will prevent the transfusion reactions by detecting antibodies mainly in the recipient serum. Means if antibodies are there and then it causes the clumping of the donor's blood, then we will not give that, and then we will test with the another blood sample. Understood here? So now the types of cross-matching, there are different types of the cross-matching is there. One is the saline cross-matching is there. So saline cross-matching is there, albumin technique is there, enzyme technique is there, and then the antiglobulin test or the Coombs test is there. So now here you see saline cross-match, it detects the immunoglobulin M antibodies. So whenever we will do the saline cross-matching, we'll do the immunoglobulin, we can detect the immunoglobulin M antibodies. So albumin technique is also there, cross-matching is also there. So it will detect the immunoglobulin G antibodies. And in case of the enzyme technique, it will detect both immunoglobulin G and immunoglobulin M antibodies. So, and now in case of the antiglobulin test or the Coombs test, it will detect the immunoglobulin G antibodies. So I told you Coombs test about little bit idea about the Coombs test, isn't it? Where I gave you a little bit idea about the Coombs test.
Erythroblastis fetalis.
Good. Okay. Erythroblastosis fetalis, or in case of the hemolytic disease of the newborn, isn't it? So there will be the fetus blood will go to the mother's circulation. It will sensitize the mother's immunity, and then after that, what happens? At first or in the initial phase, the antibodies formed are the immunoglobulin M. But later on, whenever mother is more sensitized, that time the immunoglobulin G antibodies are formed, isn't it? So here there are the different types of the cross matchings are there. So basically, you have to know the Coombs test only or the antiglobulin test. So it will detect the immunoglobulin G. So saline cross-matching, it detects immunoglobulin M antibodies. Albumin technique, it detects immunoglobulin G antibodies. Enzyme technique, it's a little bit superior. It detects both immunoglobulin G and immunoglobulin M antibodies. And then the antiglobulin test or the Coombs test, it will detect the immunoglobulin G antibodies. So it means that you are understanding my classes. So now in the routine cross matching, there are the two types of cross matching are there. One is the major cross matching and another is the minor cross matching. So now whenever I'm taking the classes, which questions will be asked in your practical viva while doing the blood grouping, that time this I'm telling. So now here, that time whenever you are doing the blood grouping in your practical, that time we can ask you questions that, okay, what are the types of cross matching? That time you have to tell there are two types of cross matching. One is the major cross matching and another one is the minor cross matching. So and then we will ask you questions like, what do you mean by major cross matching and what do you mean by minor cross matching? Understood here? So here usually we will do the routine cross matching, and then it is of two types. One is a major cross matching and another one is minor cross matching. So major cross matching means donor's red cells and then the recipient's serum is taken. Understood here? So now you may students will get confused, and major cross matching means they will say that recipient's RBCs and then the donor's serum they will say. But here you just have to remember this major means we are giving the blood to the patient, isn't it? So, or the recipient, we are giving the blood to the patient. That's why in a blood bag, whenever you will see the blood bag, which will be more in quantity, RBC will be more in quantity, or the plasma will be more? If you have a little bit idea, have you seen blood bag?
Plasma.
RBC.
RBC.
Yeah, RBC will be more, okay? Whenever you will see out of 100%, 75% will be the RBC, and then the above like 25% or about 50, we usually take the 350 ml, isn't it? So 300 ml will be the RBC, and then the 50 ml will be the plasma, understood here? So that's why we are giving the more portion of the RBCs, isn't it? So because it is, the blood is taken from the donor and then we are giving to the recipient. That's why more and more of the RBCs are there. That's why it is known as a major cross matching, understood here? So if Talwar sir would have been there, then he would have asked even why do you say major cross matching? That time you have to say that in the blood bag RBCs is more, and then more number of the RBCs will go and to the recipient. That's why it is known as the major cross matching. So in case of the minor cross matching, recipient red cells are taken and then the donor serum is taken. So in the blood bag, serum is less, isn't it? So or the plasma is less, isn't it? So we will take the donor serum and that is less. That's why it is the minor cross matching. Clear? Why it is called major cross matching? Why it is called minor cross matching?
Yes, ma'am.
Okay. There are now in cross matching is important for you, so that's why I'm repeating once again. There are two types of cross matching. So before the blood transfusion is given to a recipient, we have to do this cross matching. So it is of two types. One is the major cross matching and another one is the minor cross matching. So in major cross matching, more amount of the RBC is going from the donor, isn't it? So that's why we take the donor's red cells and then the recipient's serum or the plasma is taken. But in case of the minor's cross matching, donor serum and then the recipient's red cells are taken. So that is the minor cross matching. So now which is important out of this major cross matching and then the minor cross matching?
Major.
Good.
Major.
Major cross matching is important. Okay, you all are good. Now we'll come to the Coombs test. Somebody was asking me how we do an Coombs test, isn't it? So who was asking me that questions yesterday?
Yes, ma'am.
What's your name, please?
Ujjwal Sapkota.
What Sapkota?
Ujjwal.
I didn't understand.
Ujjwal, ma'am.
Ujjwal. Okay, Ujjwal. Okay, I'll not forget your name because I also had one friend in my MBBS time. His name was Ujjwal. Okay. So now we'll come to the Coombs test. It was now Coombs test was first described by Robbins Coombs, and then to be grateful to him or to honor him, this test name was given as the Coombs test. Understood here? So this Robin Coombs in Cambridge, he identified this or he introduced this test, or he was the one to do this test first in Cambridge in 1945. So to honor him or to show the respect to him, the test name is known as the Coombs test. Understood here? So it is also known as the antiglobulin test. Antiglobulin test, AGT means. So here we will use the antiglobulin, and then so it is also known as the antiglobulin test. It is also known as AGT. And so here this in the Coombs test, it will detect the antibodies or the complements against the RBCs. So now here, whatever antibodies are formed or whatever antibodies are there or the complements are there, it will go and attach with the RBCs, isn't it? So we can detect it with the help of the Coombs test. Understood here? So either on the surface of the RBC, we can see this complement, or in the plasma. So in case of the that newborn baby, where it was attached, these antibodies were immunoglobulin G antibodies were attached where?
RBC.
Good. Okay, on the surface of the RBC, isn't it? So it detects the antibodies or the complements against the RBCs, which may be there on the attached or the surface of the RBC, or it may be in the plasma. So this slide once I want to repeat. So mainly it was first introduced or first described by Robin Coombs in 1945. So to honor him or to show respect to him, this name was given as Coombs test, and it is also known as the antiglobulin test, AGT. And so this Coombs test is done to detect the antibodies and then the complements against the RBCs. And so this antibodies, it may be on the surface of the RBC or it may be in the plasma. So now we'll come to the direct Coombs test. So it is also known as the DAT, okay, direct antiglobulin test. So this is also known as the direct antiglobulin test, or you can even say the direct Coombs test. So that it is a little bit difficult maybe for you. So you can say the direct Coombs test or indirect Coombs test, that is also okay. So here it is also known as the direct antiglobulin test or the DAT. And then here to detect the red cell sensitized with the immunoglobulin. Direct is done on the to identify the antibodies attached on the surface of the RBC, isn't it so? So here we have to detect the red cell sensitized with the immunoglobulin G. Sensitized means, so the immunoglobulin G is attached on the surface of the RBC, or the complement components, that is the example C3 is attached on the surface of the RBC. Understood here? So the direct Coombs test, it is important to identify the antibodies in case of the hemolytic disease of the newborn, hemolytic transfusion reaction, autoimmune hemolytic anemias, and then the drug-induced hemolytic anemias. So its uses are important in case of the hemolytic disease of the newborn, hemolytic transfusion reaction, autoimmune hemolytic anemia, everything is hemolysis, isn't it? So here, so drug-induced hemolytic anemia. If you don't remember other remaining three, but you have to remember the hemolytic disease of the newborn. Understood here? So I'll repeat the slide once again. This is also direct Coombs test is also known as a direct antiglobulin test, and it will detect the red cell sensitized with the immunoglobulin G or the complement C3. Means red cell sensitized means now this immunoglobulin G or this complement C3 is attached on the surface of the RBC. So the Coombs test is done, or it is important for the hemolytic disease of the newborn, which we talked a little bit yesterday. And then hemolytic transfusion reaction. So hemolytic transfusion reaction means after the blood transfusion, there may be the hemolysis. So that time we will do this Coombs test. So hemolytic transfusion reaction. And in case of the autoimmune hemolytic anemia, autoimmune means, so our body will form the antibodies against our own cells, isn't it? So in case of the autoimmune hemolytic anemia, and in case of the drug-induced hemolytic anemia. So drug-induced hemolytic anemia, some drugs, it will act as the antibodies, and then it will attach on the surface of the RBCs and it causes lysis. So it is also known as the drug-induced hemolytic anemia. So now how we will do, see here. So for doing the direct Coombs test or this DAT, direct antiglobulin test, so fresh blood with anticoagulant is required. Understood here? It may be from the patient or it may be from the baby. So in case of the hemolytic disease of the newborn, it was from the baby, and we yesterday I told you that we will take the 20 ml of the blood, cord blood, isn't it? So fresh blood is taken, and then it is with the anticoagulant. Anticoagulant is the EDTA is there. So we can use here anticoagulant EDTA, mixing blood. And then blood can be taken from the patient and then the blood. If it is the baby or the hemolytic, to identify the hemolytic disease of the newborn, we will take the cord blood 20 ml. So here we also need the anti-human globulin serum or the Coombs this serum. Understood? AHG serum, anti-human globulin serum or the Coombs serum is required. Understood here? So RBC from the patient and then the baby is mixed with the anti-human globulin or this Coombs serum is mixed. Now RBC is taken in the anticoagulant, that is the EDTA, so that the sample taken, it will not clot. EDTA, it will help or it will prevent the clotting of the blood. Then we will add this RBCs from the patient, and then the baby is mixed with the anti-human globulin, that is the serum. Understood here? So if the RBCs are coated with the antibodies, then the Now this anti-human globulin, what it will do, it will make the whatever coated cells are there with the antibodies, it will clump together and then it will show the agglutination. So if agglutination is seen, then it is reported as the direct Coombs test positive. This slide is clear? Did you understand this slide? No?
Yes, ma'am.
I think only one. Yes, I'll tell again. So here we'll take the patient's blood or the baby's blood. Let's talk about patient is also, we can do the direct Coombs test in the patient also. Or and now, yesterday I told you about in case of the hemolytic disease of the newborn, isn't it? So now we'll take the blood, and then the blood should be taken in the EDTA. So here the anticoagulant we will take because the blood will not be clotted, isn't it? So we cannot do in the clotted blood this direct one. So that's why the blood, it should not be clotted. So we will use the EDTA. And then now that blood of the baby and then the patient, it is mixed with the anti-human globulin serum. It is mixed. Now if the RBCs or whatever that sample we have taken, if those cells or the RBCs are coated with the antibody, then this anti-human globulin, it will make the aggregation of the cells RBCs. So I'll show you the picture. With that maybe you'll understand more. Then we will see the agglutination or the clumping of the RBCs. So we can report it as the positive test or the direct Coombs test positive. Understood here? So now you see here in this picture, this slide is, you can see? This slide, can you see?
Yes, ma'am.
Okay. Now you see the left side picture. So now the blood is taken in a test tube, isn't it? So usually we will take the EDTA blood so that the blood will not clot. Now whatever blood is taken, that is already coated with the antibodies, isn't it? So it may be the immunoglobulin G or it may be the C3. It is already coated. That like inverse Y, you can see. So it is coated with these antibodies. Now these RBCs are coated with these antibodies. So now though it is coated with the antibodies, it is not showing the clumping of the blood. It is separate, isn't it? So that's why we will add the anti-human globulin. Did you understand here? So AHG we will add, and then this Coombs sera we will add, and then now the Coombs sera will have all these antibodies. Understood here? So now this Coombs sera, whenever it will act on these antibody coated RBC, so it will help in the aggregation of the RBC. So you can see here it is clumping with each other on the right side. So it was separate on the left side, and then whenever the AHG or this Coombs sera is added, and then now it is clumping with together and it is joined, isn't it? So can you make out?
Yes, ma'am.
Only one, yes.
Yes, ma'am.
So now basically RBCs in the blood, it is already coated with the antibodies, but it will not show the clumping of the RBCs. It is separate. So now we will take the RBC blood, we'll take the blood, and then we don't allow it to clot. Whenever blood is taken out, it will clot, isn't it? So for the to prevent the clotting of the blood in the test tube, we will add the EDTA, and then it is not showing clumping. So now here we will add this anti-human antibodies. Understood here? So anti-human antibodies. So at the center you can see the purple Y, isn't it? So like antibodies, Y-shaped arrows are there. So now whenever it is added in these, now this whatever antibodies are attached on the RBC, it will try to attach together with the two that limb-like thing, isn't it? So now it will show the clumping of the blood. Now the direct Coombs test become positive. So now we'll come to the indirect Coombs test. So now this is also known as the indirect Coombs test or indirect antiglobulin test or IAT. So the previous one was the direct, that is the direct antiglobulin test, and That's why that was DAT. But now this is the indirect antiglobulin test, and then the name is the IAT. So here we have to show this test is indirect. So here we want to detect the antibodies present where? Just tell me if anybody.
Serum.
Plasma.
Okay, plasma or in the serum. Okay, anything you can say. So now here we want to detect the RS antibody or other type of the antibodies in the patient's or in the mother's plasma or serum. Understood here? So here we want to detect these antibodies are present or not. So now here what in the plasma of the mother, in case of the this hemolytic disease of the newborn, there will be the immunoglobulins were there, immunoglobulin G antibodies were there, and so, and in some patients also we can detect these antibodies. So here its use is for the RS negative mother with the RS positive fetus. So it will lead to the hemolytic disease of the newborn. So indirect test we can do in case of the RS negative mother with the RS positive fetus, and also in case of the hemolytic transfusion reaction. And then we can also do the titration of the antibody in case of the unknown serum. Understood here? Unknown serum means, suppose if or in case of the this amniotic fluid. Do you know what do you mean by amniotic fluid? So amniotic fluid means, so the baby is there, isn't it? So in the sac there will be the fluid will be there, isn't it? So that is known as the amniotic fluid. Understood here? So now here we can do in this test in these cases. One, in case of the RS negative mother and when the baby is RS positive, and in case of the hemolytic transfusion reaction, so hemolytic transfusion reaction, so we want to detect whether the plasma is having or the serum is having any antibodies or not. And also in case of the titration of the antibody in case of the unknown serum. So whenever antibody is there in the serum, that time we want to see the titration. So how much is the antibodies there? Is it less in amount or is it high in concentration? So that we want to see doing the titration. Titration means, so we will do in the different solution concentration, that is known as the titration. This slide is clear? So if you don't remember the uses the first you have to remember. So indirect Coombs test, it is also known as the indirect anti-globulin test or the IAT. And so here we will we want to detect the RS antibodies in the mother's plasma. And so its main use is the RS negative mother with the RS positive fetus. So this you have to tell. If later on other points you don't tell, I don't mind, but this RS negative mother with RS positive fetus you have to tell. So now in the procedure, so here we want to detect the antibodies in the plasma or in the serum, isn't it? So that's why here the clotted blood sample is taken. So the blood clotted sample from the patient or the mother. Okay, so that sample is taken, and then we have to have this anti-human globulin or the Coombs sera, and then here blood is already clotted and RBCs are clumped, isn't it? So now the serum is having the antibody. So now the serum, it has to attach on the surface of the RBC, isn't it? So now we will use the RBCs. Which RBCs we will use? Now there will be cells are there, so that those cells are the O blood group, with the O blood group. So RS positive it has to be. So now the O blood group cells. So surface of the O blood group, is there any antigen?
No.
No.
Okay, there are no antigens, isn't it? So that's why we use the O blood group, isn't it? So now here the O doesn't have this antigen A, antigen B, isn't it? So that's why as a control we will take the O blood group, that is the O positive red blood cells. Now first step what we will do, serum from the sample is mixed with the O positive this blood samples, understood here, or the RBCs. Now serum is there and serum is having the antibodies. We want to detect that one, isn't it? So now if the antibodies are present, now these antibodies will attach on the surface of the RBCs of this O blood group. Understood here? In the first step, serum from sample mixed with the ORS positive RBCs. It means that serum, whatever the clotted sample was taken, that serum is there. After the blood clot, serum will be there, and that serum is taken and then mixed with the O positive blood. So this whatever antibodies are there, so that antibodies will attach on the surface of the O positive blood. Understood here? So now in the second step, now the antibodies will attach on the surface of the RBC, but it will not show clumping, isn't it? So as in the case of the direct Coombs test, it will not show the clumping. So in the next step, we have to add the anti-human globulin serum we have to add, or the Coombs serum we have to add. Now if the RBCs are coated with these antibodies or immunoglobulin G or the C3, then it will show the agglutination. Now you see, finally, if agglutination is seen, then we will report it as the indirect test positive. This slide, did you understand?
Yes, ma'am.
Everybody, did you understand?
Yes, ma'am. Yes, ma'am.
Or should I tell once again?
Yes, ma'am.
Now
Yes, ma'am.
here, don't look at the slide, all those steps, okay? You just listen to me then. So now here the clotted sample is taken, and now we want to identify the antibodies in the serum or in the plasma, isn't it so? So that clotted sample is taken, and then the plasma, after the blood is clotted, we will take out the plasma. Understood here? So now here plasma is taken, and then as a now these antibodies, whenever the plasma is only taken or the serum is only taken, now these antibodies, it has to attach on the surface of the RBC so that we can see with our own eyes the clumping. That's why we will take here the red blood cells of a person who is having the O blood group. Understood here? Usually we take the not O negative, but we'll take the O positive red blood cells. So in the first step, that serum of the sample where we want to identify these antibodies, we'll mix this O blood group RBCs and then the serum. So whatever antibodies are present on this serum, that will coat or it will attach on the surface of the RBC. So now whenever these antibodies are attached on the surface of the RBC, so we cannot see or we cannot detect it. So to see the clumping of the RBCs, we have to add finally this Coombs sera or this anti-human globulin. So whenever anti-human globulin is poured or is dropped there, so the RBCs coated antibodies will clump together and it will show the agglutination. So now if it will show the agglutination, the test will report it as the indirect Coombs test positive. So the second step is similar to that of the direct one. Now it is already coated with the antibody. Now as in the direct Coombs test, we added the anti-human globulin, and then it will cause the clumping or the together, it will join the RBCs together, making it the agglutination. Clear? So now this picture I want to explain to you. So now you see here, in case of the indirect Coombs test, we take the serum from the clotted blood, isn't it? And then the serum is having the antibody. So you can see on the left side, you can see the antibodies, that something like Y signal like, isn't it so? So these are the antibodies, isn't it so? Now we will take the RBC from the O positive blood, isn't it so? So now in case of the O positive blood, so it will act as a control, and then whenever we will mix these serum having the antibody, so now in the next step you can see the RBCs together antibodies in the center. At the center you can see antibodies are there attached on the RBC, but the RBCs is not showing clumping. So we have to see and identify that whether the test is positive or not. So we will add the anti-human globulin, and which is having the antibodies. So now after adding the anti-human globulin, the test result positive. So now it is making the joining the RBCs together, and we can see with our own eyes the clumping of the RBCs. So now if it shows the clumping of the RBCs, it becomes the test indirect Coombs test positive. Clear with this picture? Did you
Yes,
understand?
ma'am. Yes, ma'am.
Okay, how many of you understood? Raise your hand. Now, if the indirect Coombs test is positive, next step is to check the titration of the antibody in the mother's serum. So now the indirect test also, first it was the direct test positive, and then it also became the indirect test positive. So we want to see how much antibody is there in the mother's serum, so that here the serum is diluted with the different dilutions with the ICT. And the indirect Coombs test is done in each. So now here we want to see how much is the concentration of these antibodies in the mother serum. So we will dilute the mother serum in different concentrations. So at one level we will see that there is this much concentration, and we will see the agglutination. So that's why it will indicate the degree of the production of the antibodies. Understood here? So basically, after doing the after coming the indirect Coombs test positive, we want to see how much antibody is there in the mother. So we will the mother's serum, we will make it the different concentration, 1:10, 1:20, 1:30, like that. Different concentration we will see, and then at which level it becomes positive. So we can tell that, okay, antibody is produced in this much concentration. Understood here? This slide is clear? So I'll read this slide once again. Next step is to, after the indirect Coombs test is positive, now we want to see the titration of the antibodies in the mother serum. Now the mother serum is diluted to the different solutions, and then the indirect Coombs test is done in each concentration, like different concentration we'll make, and then each concentration we want to see. And then we will see the agglutination is formed at which dilution. So if it is formed as 1:10 or 1:20, so we can know by this that how much is the antibody production. Yes, please. Anybody want to say something? So in the summary, like, so if RS negative mother and then the RS positive fetus is there, then cord blood we will take, and in the cord blood we will do the direct Coombs test. Then if it is positive, if direct Coombs test is positive, in the next step we'll take the mother serum and we'll do the indirect Coombs test. Then if it is again positive, then we will do the titration of the antibody in the mother's plasma. Clear this slide? First we will take the baby's blood and we'll do the direct Coombs test. Then if it comes positive, then in the next step we'll do the we'll take the mother's sample and we will do the indirect Coombs test. And if that is also positive, then we will do the titration of the antibodies in mother's plasma. Mute your mic, please. So for you to do the little bit mnemonic is there. So to identify the RSD disease, it is checked on the RBC by the direct Coombs test. Understood here? R for the RS, it is done in the RBCs in the direct test. We will do the direct Coombs test. So you have to know here basically mainly the direct Coombs test is done on whose blood? Is it done on mothers or it's done in the babies? So that time direct you have to tell in the baby's blood we have to do, and then indirect we will do in case of the mother's blood. So in babies, where is the antibody coated? So that time you have to tell on the surface of the RBC antibodies are coated. Now in case of the mothers, so antibodies are there in the serum or in the plasma. This I already told you, direct Coombs test, it detects antibodies coated on the surface of the red cells, when it is sensitized and taken place in vivo. And indirect Coombs test, we want to demonstrate the antibodies present in the serum. Are you understanding? Or it became too much? So now this picture you see, so here the direct antiglobulin test is there, and then the direct antiglobulin test is there. In the first picture, now the RBCs are itself coated, isn't it? So it's itself coated with the antibodies. So now here it is coated with the antibodies, and then we will add the, but it is not showing the clumping. So whenever we'll add this anti-human globulin or the Coombs reagent, then what it does, this something like one robotic like picture is there, isn't it? So having many arms. So now it will attach many RBCs, so it will show the clumping. Now here, in case of the indirect, the plasma or the serum is having the antibodies, so it is separately there. But now we have to add the RBCs, isn't it? So here we will, whenever we will add the O positive blood or the O blood group RBCs. Now the RBCs, whenever it is added, these antibodies are coated, and then finally, like in case of the direct, we will add the anti-human globulin. Now this anti-human, it has got many receptors are there. So here it will attach the many RBCs, so it will show the clumping of the RBCs. Clear? Are you listening?
Yes, ma'am.
Okay.
Yes, ma'am.
Okay, not much slide is there. 2-3 slides are there. Can I finish the slides?
Yes, ma'am.
Now blood is collected under blood storage. Blood is collected under aseptic precautions. So we have to take it with the very full aseptic precautions we will take. And then blood is taken in a sterile plastic bag. It is used for collection. And blood and anticoagulants should be gently mixed during the collection process. So this you must have understood the first sentences, isn't it? So blood is collected under aseptic precaution. So we will do it under aseptic precaution. There should be no infection. Everything should be clean and sterile. So blood is collected in the sterile plastic bag for blood collection. And here you see blood, and then the anticoagulants would be mixed gently during the collection process. So here, you know, whenever the blood comes out from our body, then it will try to clot, isn't it? So here, after the blood goes in that blood bag having the anticoagulant, this CPDA, so we have to mix it gently so that the blood will not clot. So anticoagulants like ACD, CPD, CPDA is used, and then the citrate chelates the calcium and it prevents the coagulation. This slide is not very difficult. Did you understand this? So mainly you have to know is blood and anticoagulants should be gently mixed during the collection process. So you must be thinking, what do you mean by this, isn't it? So now after the blood is collected in the bag, at the initial phase, so we have to mix gently with the anticoagulant which is present there in the blood bag so that it will not clot later. And we use different anticoagulants. This I have already told you. And how the citrate does preventing that also I have already told you. It chelates the calcium. Now the collected blood is stored at the temperature of 2 to 6 degrees Celsius, but usually here in our blood bank will maintain in between, that is the 4 degrees Celsius. And then the anticoagulants, this I already told you also, the ACD and then the CPD. Whenever these anticoagulants are used, the blood is stored for 3 weeks, and whenever the CPDA is used, then the blood can be stored for 5 weeks. Now we will see the basic screening test. This is also important for you because in your Viva will ask you what are the tests done on the donor and what are the tests done on the recipient. Understood here? So basic screening test you have to remember. So This you can mark is, or you can remember that, okay, this is important. So now here following tests are carried out on each blood sample or the donor's blood, which this test will be done. So in the donor's blood, ABO and then the RH grouping is done. So we have to know that which blood group it is, whether it is A positive, B positive, or the AB. So on that donor's blood, we have to do the HBS AG. Understood here? HBS AG is done for which purpose? Tell anyone? Okay, it is done for the hepatitis B virus. Okay, HBS AG is done for the hepatitis B virus, and then we will also do this anti-HCV, means it is done for the hepatitis C virus. Anti-HCV test we will do, and then the anti-HIV test also we will do, and we will do the syphilis test, and in case of the this malaria prone areas, we will do the malaria test. So this basic screening test you have to remember. And it is important also. So in your practical, we can ask you what are the basic screening tests done in the donor. Usually we don't ask recipient because there only the ABO blood grouping and RH grouping is done. So here in case of the donors, ABO and RH grouping is done. Or if you cannot say HBS AG, you have to say that hepatitis B virus, hepatitis C virus, or HIV test we have to do. So that you can tell. And we will do for the syphilis and malaria. Can you tell? Can you tell what are the tests we will do? Now, Anulekha, can you say what are the tests we will do in the donor's blood?
Yes, ma'am.
Okay, what are the tests we will do? Tell.
ABO.
ABO blood grouping, and then another one. What grouping?
RH.
Good. Then
RH and HBS.
AG.
Hepatitis B virus. Hepatitis C virus. Syphilis. Malaria.
And one more, HIV. Okay.
HIV.
So first here we will do 5 tests. First one is you have to know the blood grouping, isn't it? So you have to know which blood group it is. So that's why we will do the ABO blood grouping and RH. Then we have to do this hepatitis. So hepatitis B, for that hepatitis B, we will do the HBS AG. And then for the hepatitis C, we will do the anti-HCV test. That is the hepatitis C virus. And also for the HIV AIDS, we will do the anti-HIV. Understood here? The syphilis we will do here, but here malaria is not done. But in India or in other countries, even the malaria should be done. So you have to remember this. Now the test done on recipient blood, only here we will do the ABO and then the RH grouping. So in the recipient, we don't have to do this HIV, HBS AG or this hepatitis B, hepatitis C, malaria. So only we will do in the recipient blood, ABO and then the RH grouping. Clear? Did you understand today's class?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Any questions? Do you have any questions? Ranjan Yadav, are you there?
Yes, ma'am.
Okay, did you understand?
Yes, ma'am.
Okay. What are the tests, basic screening test in blood bag? What donor's blood? What we will do? Tell Ranjan Yadav.
Yes, ma'am.
Basic screening test in the donor's blood. What test we will do? What are the tests?
ABO, RH,
Good.
HIV, malaria, hepatitis.
Okay, hepatitis B, hepatitis C, HIV. Okay, if you cannot say HBS AG, you can say we will do the test for the hepatitis B, hepatitis C, and HIV. If you say that much is also okay. Syphilis and malaria. Ujjwal, dear, are you there?
Yes, ma'am.
Okay, you have any questions?
No, ma'am.
Okay, today's class is clear then. Okay, Nabin Bhandari, are you there? Nabin? Okay, Ankita Kumari, are you there? Shimran? Okay, I hope students are not there. Okay, thank you for listening and coming. Now I'll upload this today's slide. Okay, thank you. I'll hang up now.
Thank you, ma'am.
Thank you, ma'am.
Okay.